Hi, this is Brian Kim. I want to share with you case number 229 in the best way to do cataract surgery series. And again, the purpose of this title is not to suggest this is the best way, but to get you to think about your best way that you can offer the patient cataract surgery. And that means scrutinizing your cases and looking to refine and honing your techniques. And by doing so, you'll be able to provide the very best for the patient. And so I'm going to show you this case of significant zonular laxity. And even at the end of the case, I'm going to place a capsular tension ring. You'll be able to see from the entire case from start to finish all the key signs of zonulopathy that I'm able to identify because I'm paying close attention and also because of the way I perform cataract surgery. So I use a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size the rhexis. The cotton tip is quite helpful because I'm not grabbing the eye, and therefore the patient won't have any discomfort with that particular step. Using the cotton tip to steady the eye for my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea using the cannula to control the eye, and then I enter. So far, no evidence for zonulopathy because why? I haven't messed with the capsule yet, and I haven't messed with the zonules. So go ahead and use the micro forceps to puncture the center of the capsule, pull down towards me, and then nudging the capsule to the right side. But look here, you see those wrinkles right there? Those wrinkles are signs of zonular laxity because the zonules are not holding the capsule tautly in the periphery, and that's what causes those wrinkles. So that's sign number one. And as I go around, I'm trying to, again, extend that capsule flap, and then I'm starting to pull across, but take a look. As I'm pulling across, you can see these stria lines in the capsule, again, peripheral to the tear. So right, as I'm pulling that flap and creating that tear, you're seeing the leading edge of the capsule folding on itself. As you can see right here, these stria lines again in the front side of my tear. As I'm pulling, you're seeing those traction lines. Again, why does that happen? Because the zonules are supposed to be offering circumferential stretching of the bag, but that's not happening. There's some laxity, and therefore you're seeing these folds, almost like radial type folds. They're radial and perpendicular to my tearing force. So again, if my tearing force is being pulled, the stria lines are perpendicular to that force. And over here, as I'm pulling towards my cannula that's holding the eye steady, you can see again some unusual kind of S-shaped wrinkles and folds in the anterior capsule. Again, all of this is to say, throughout the rhexis, I'm saying to myself, okay, this patient has significant zonular weakness. But I'm able to achieve a really well-centered and sized rhexis, very controlled rhexis with these microforceps, using a two-handed technique with cannula. Irrigating the surface of the eye. And then I'm placing the dispersive viscoelastic on the cornea. Again, a nice wet eye and removing any potential debris, and then coating the cornea after that, dripping some BSS to get a uniform surface. So take a look here. You see the wobbling of the lens as I go in with that cannula from a hydrodissection. So that's the other sign. The wobbling of the lens as I try to go ahead with my hydrodissection wave. So I get a nice wave. I'm able to very carefully and very gently decompress the bag. I did not overinflate and cause capsule block, right? I mean, if you overinflate and cause capsule block, when you have loose zonules, you might not be able to release that capsule block. So that's, another issue. So you want to be very gentle as I did. Got a nice wave, but then I stopped. I didn't want to overinflate the bag and cause that capsule block. I swept on the left side and then now the right side, and then being very mindful as I'm trying to loosen the lens from the bag. So just gently tapping, no forceful and aggressive forces on the zonules in the bag. See, and then the lens begins to spin. Lifting the incision with the chopper, going in with irrigation off to minimize decimase trauma. I'm a little bit concerned about reverse pupillary block, so I go ahead and make sure I lift that iris with the chopper, and then I start to remove the surface epinuclear material. Place the chopper under the rexus edge contra-incisionally, tilting the phaco tip vertically sub-incisionally, and I fracture the lens completely in half by flanking the lens with the chopper and the phaco tip. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centered toward the phaco tip, and then crushing the lens against the phaco tip, and the phaco tip is acting like a chopping block. Placing the chopper around that first quadrant, and then lifting it with the phaco tip. Once I lift it, I get around it with the chopper, and then crushing the lens between the instruments. Throughout this case, I'm very mindful of the zonules. Again, I saw signs of zonulopathy early on. You don't want to encourage any traction on the zonules, and I want to make sure I keep my phaco tip away from the posterior capsule. Very gently, I'm trying to separate the second quadrant from the rest of the lens, hooking the peripheral lens with the chopper, making sure I place that phaco tip fairly deep between those pieces. By flanking the lens with the phaco tip and chopper, I'm able to crush the lens in half. Once I crush the lens in half, go ahead and start crushing the lens some more with the instruments, and then emulsifying the lens piece. You can see I'm very gentle, very careful, and using mechanical forces, I'm able to mobilize the lens pieces without causing any zonular traction. I'm not trying to push on the lens, push on the zonules, and do any aggressive moves. And why? Because I'm able to use my instruments to manipulate the lens very effectively, especially because the chopper has that great hook, and I'm able to hook the lens with that chopper. Loosen that fragment with the chopper, crushing the lens between the instruments and emulsifying the lens piece. Very gently and carefully turning that second heminucleus, and then grabbing it with some vacuum, lifting it up, getting under it with the chopper, and then crushing it between the instruments, and then again using successive crushing forces to crush the lens into smaller and smaller pieces, and then using pulses of ultrasonic energy and vacuum to remove the lens pieces. This is the last quadrant, lifting it up with some vacuum, making sure that the bag is not adherent to that lens fragment. Again, getting underneath it with the chopper, crushing the lens in half with the instruments, and then emulsifying the lens pieces, and then going after that last fragment with some vacuum, crushing it between the instruments, getting underneath it with the chopper, and then emulsifying the lens pieces. So again, very careful, methodical lens disassembly without causing any zonular traction. Carefully removing the epinucleus, and I always want to make sure that the epinucleus is disengaged from the bag. You want to be very careful with this step. You don't want the bag to be attached to the lens pieces, and then you might actually grab the bag, and which is not good, especially in a case like this. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, peeling from anterior to posterior, but take a look. As I'm peeling and I'm pulling with a central force, look at the puckering of the posterior capsule. So that's the third sign. So the first time is for the rexus, the second time was hydrodissection, and then the third time is during IA. And so as I'm peeling, you see I'm pulling centrally with the IA forces. You could apply some tangential force as well. But as I'm pulling, you're going to see these very fine stria lines in the capsule as I'm peeling the cortex off the capsular bag. And so I'm going to go ahead and continue to peel it off. I did have some stria lines earlier. I didn't pause it during that moment, but I'm going to go ahead and pause it right here. As I'm peeling back, you can see these fine stria lines right there on the capsule. And why is that? Because as I am exerting that peeling pressure on the cortical material, it's causing that puckering of the capsular bag and causing those radial stria lines. Quickly switch to polish mode because you don't want to exert any high vacuum and aspiration pressure on the zonules in the capsular bag. Very carefully and being mindful as I'm using the polish mode. not to cause any more zonular stress. You can see I'm puckering the posterior capsule quite a bit here. And the puckering of the posterior capsule, again, is what I call the spider sign. The spider sign is when you see those stria lines as you're trying to polish the posterior capsule. And when you're puckering the posterior capsule, you get those stria lines in the posterior capsule. Again, another sign of weak zonules. Pulsing BSS into the subincisional capsule fornix. You can see it starts to loosen up some of that material. So that's, again, a nice way to just flush out some of that stubborn cortical material and to clean out the bag. And you can see, even with the pulsing of the BSS cannula, you can see the stria lines in the capsule. Because why? As I'm pushing the BSS, it's causing the capsule to collapse, and the force of the BSS is causing the stria line in the posterior capsule. Go ahead and fill the capsular bag with cohesive viscoelastic, and then I'm using the sweeper to polish under the rhexis edge, first on the left side, and polishing the lens epithelial cells, making sure that the bag is nice and clean. This is particularly important in cases where you have weak zonules, and you want to make sure that the bag is nice and clean. You don't want to have any capsule contraction in a case like this. And this is a capsular tension ring. You can see I'm just moving and nudging the eyelet so it's over that vertical kind of like indentation. I like to place the hook facing down, and it gets right into that eyelet. So I have good visualization, and I made sure that the eyelet gets very nice and seated within that hook. Lift the incision with the Lester, and then hooking the first eyelet with the Lester as I advance the CTR. Again, minimal torsional stress on the bag with this technique. And then just go ahead and deposit that trailing haptic into the bag. This is a single piece acrylic lens. It's going into the capsular bag as well. Again, very efficient way to place the CTR in within the bag using the Lester, and again, minimizing torsional stress on the bag. Getting underneath the lens, removing the viscoelastic from within the bag. And be mindful now as I'm doing this, you can see the lens is quite a bit jiggly within the bag. You can just appreciate some of the wobbliness of the lens as I remove the viscoelastic. Oh, there's a big chunk of lens material. Go ahead and mash the lens material into the tip with the cannula. Switching to visco mode to increase that vacuum and aspiration pressure. Crushing the lens again into the port. Going to polish mode now, making sure I polish under the rhexis edge. Rotating the lens just a little bit here. Making sure I'm really getting it nice and clean. I'm a little bit obsessive about cleaning the anterior capsule. Switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So look, I have a beautifully well-centered and sized rhexis, but you're going to see with that high infusion pressure and the vacuum, the lens is rather wobbly within the bag. And again, all of this is just to validate what I was saying before, that I saw signs of zonulopathy from beginning to end of the case. So again, first I saw it during capsular rhexis, the stria lines as I was doing the rhexis. And then when I did hydrodissection, as I placed the cannula and I was trying to slide it under the rhexis edge, you saw the entire lens was wobbling. Okay, and then number 3, then you saw during cortical removal, you saw the strial lines as I was peeling the cortex off the bag. There was strial lines within the bag as well. And then 4th, when I was pulsing BSS into the capsule fornix, you saw the stria in the posterior capsule from that high infusion pressure. And finally, at the very, very end of the case, as I'm removing the viscoelastic from the eye after the lens is put in, you can see quite a bit of jiggling of the lens implant when I'm removing all that viscoelastic. And this is a very final sign, just as a confirmatory sign, as I go ahead and hydrate the incisions and I make sure the wounds are sidel negative. As I have the patient look side to side, look how much wobbling there is of the lens itself. There's quite a bit of wobbling of the lens. I'm having the patient look side to side. And you can see there's just very fine IOL denesis, wobbling of the lens within the bag. So again, capsular tension ring does not prevent late IOL dislocation, but a capsular tension ring can be a scaffold for when you want to scleral fixate the lens by lassoing the CTR. You're able to just stabilize that dislocating lens and keeping and maintaining the lens with the CTR complex rather than having to remove the entire lens and performing Yamane technique. So again, these were the key signs I saw throughout the entire case of severe zonulopathy, and you saw how I was able to manage it, performing double chop, cross chop, mechanical fracturing concepts and principles, minimizing torsal stress on the bag, and then placing a capsular tension ring at the end of the case. So I hope this was helpful to you, and I thank you for your attention.